And we're back, my friends. Welcome back to Cardiac Academy. In the last few videos, we talked about rhythm, arrhythmias, heart rate. So this video is all about access and hypertrophy. Easy topic, but equally important. So let's get started. Okay, let's talk about access. So when we talk about access, what we're really looking for is the direction of the vector of depolarization. So if you remember from our previous lectures, all depolarization should start at the SA node, and from the SA node it will travel down to the AV node, and then from the AV node down the His-Purkinje system to the ventricles and depolarize, right? So it does so in a rightwards to leftward direction, and from the top of the heart to the bottom of the heart. So if we look here at what is called the His-axial system or the His-axial reference system, we should see that that depolarization should be between -30 and 90, just like we see here. Okay? So the way that we assess for access is by looking at lead 1 and lead AVF, and we'll practice together. So some people like to think about that as 2 thumbs up. So if you look at lead 1 and it's positive, and you look at AVF and it's positive, that's 2 thumbs up, that's a normal axis, okay? So since we're talking about thumbs up, why don't you leave us one of those down below, okay? All right, thank you, appreciate it. So let's practice, okay? So first, and by the way, I think I forgot to mention this. When we talk about positive deflections and negative deflections, what we mean is that the electrode is recording either a depolarization coming towards it, that's a positive deflection, or if it's a negative deflection, then the electrode is actually recording a depolarization going away from it, okay? So thinking about that, let's look at lead 1. So if we have a positive deflection on lead 1, that means that the electrode is recording a wave of depolarization coming towards it, okay? So we look towards it, just like this. And then we look at AVF, and we see the same thing, it's positive. So that means that the electrode is recording a depolarization coming towards it, so the same. And then we add those 2 vectors together, okay? So that means that we're gonna have a normal axis because it's between 0 and 90, so that's a normal axis, okay? So let's say normal. Now in the next example, we see that we still have a positive deflection in lead 1. So we see here is positive, so it looks the same way. But now we have a negative deflection in AVF, so the depolarization is looking away from it. So it will be away from AVF. AVF is in the bottom, so away from it. And here, if we add those together, we have a possible left axis deviation, and I'm going to explain why possible later on, okay? So let's say possible left axis deviation, okay? All right, next example. Then we look at lead 1, and we see a negative deflection, so it's looking away from it, just like this. And in AVF, we see a positive deflection, so it's still looking towards it. So we'll look like this. Add those together, and what do we have? We have a right axis deviation, okay? And finally, let's choose another color. We have a negative deflection in lead 1, so it's looking away from it. And then we have a negative deflection again on AVF. So it's looking away from it. Sorry, so this is negative deflection of AVF right here. And then a negative deflection at lead 1, looking away from it, just like this. Add those together, and what do we have? We have an extreme right axis deviation, okay? All right, very good. Okay, so here we have a summary of what we just talked about. Remember that when you have 2 thumbs up, that means you have a normal axis. Look at lead 1 and AVF. 2 thumbs up, normal axis, okay? Feel free to take a screenshot if you want. Let me just pause for you. There you go. So earlier, I said that when you look at the second example, you can see that the axis is between minus 90 and 0. So there's a possible left axis deviation, okay? So why possible? Because we can't tell for sure whether the vector of depolarization is going beyond minus 30. So as you can see here, it's between 90 and 0, okay? 90 and 0. So how do we make sure it's still normal? So for that, we look at lead 2. Let me show you how. So we're saying that in lead 1, we have a positive deflection. So that means that the wave of depolarization is going towards it. So let's draw that. So it's towards it. And then in AVF, it's negative. So it's going away from it. So away. Now, how do we know whether it's going beyond minus 30? So we look at lead 2. So if we have a positive deflection in lead 2, that means that the wave of depolarization is going towards it, right? So it's going this way. And if we add those together, when we sum up the vectors, it's gonna like something like this. Let me change color. It's gonna be something like this. As you can see, it's not between 0 and 90, but it's not beyond minus 30, okay? And that's how we know it's still normal. Now, let's do a different example. Let me just clean this up. And let's say that again, it's looking towards lead 1 and looking away from AVF. But now let's say that instead of lead 2 being positive, having an R wave, now it has a dominant S wave, so it's negative. So that means it's looking away from it. So let's draw that. It's away from it. So if we add these together, the vector of depolarization is going to look more something like this. So now it's lying beyond minus 30. So now we know that, yes, in fact, there is a left axis deviation, okay? All right, let's continue. Okay, let's do a real life example. All right, so we said that we're gonna look at lead 1 and we're gonna check whether it is positive or negative. So lead 1, we can see it's a positive deflection, okay? So that means that it's looking towards it, the wave of depolarization towards the electrode in lead 1. Then we look at AVF, and we can see that AVF is actually negative. So it's looking away from it, okay? So away from it. And now we see that the vector of depolarization is between minus 90 and 0. So there's a possible left axis deviation. So what do we do when there's a possible left axis deviation? We look at lead 2, correct? So lead 2, we can see, is positive. So that means that that wave of depolarization is looking towards lead 2. And when we add those vectors together, we know that it should not lie beyond minus 30. Okay? So it should still be normal. So it is a normal axis, okay? Now, here we can see, just like we said, we have a normal axis, but I also want to give you a pro tip, okay? So when everything else fails, you can look at the PRT axis, okay? And this number right here will give you the degrees of the wave of depolarization. So in this case, it's minus 9. So you can see it doesn't lie beyond minus 30. So it's normal axis, okay? Very good. All right, so here we have some examples of possible causes of left axis deviation and right axis deviation, okay? So for left axis deviation, we have the classic left ventricular hypertrophy, but we can also have left bundle branch block, Left anterior hemiblock or fascicular block can also cause it. Ventricular pacing, when you have a pacemaker. In the right axis deviation, then we have right ventricular hypertrophy, left posterior hemiblock or fascicular block, right bundle branch block, dextrocardia, which is more rare, although I've seen one in my lifetime. And I'm still kind of young, so I'm hoping to see more. But we'll go into each one of these possible causes in future videos, okay? All right, so left axis deviation in the setting of left ventricular hypertrophy. So let's try to imagine a possible patient. So let's say you have an elderly patient who has been battling with hypertension for years and years. So as you can imagine, just like any other muscles in our body, as when we train them, they'll get bigger and stronger. So the same thing happens with the heart. So when the heart has been trying to propel blood forward against the system for many years, and then you have high blood pressure, then the heart needs to work even harder to move that blood forward. So it needs to get bigger and stronger. You develop hypertrophy, okay? So when you develop hypertrophy, the bigger the muscle, the stronger the electrical activity, and that vector is gonna move more towards the left axis, right? And we're gonna have a left axis deviation. So the same can happen with right axis deviation. However, in right axis deviation, it's more about COPD, the usual cause, right? So it's far less common than left axis deviation, but you will still see it from time to time. And like we said, COPD and an uncorrected congenital heart disease, in which you can have shunts, can also cause this, okay? All right, so left axis deviation, okay? So when you have left axis deviation, it can be associated with left ventricular hypertrophy, but left axis deviation alone is not enough to diagnose left ventricular hypertrophy. For those, we use some criteria. In this video, I'm gonna teach you the most commonly used ones and the ones that I personally use, okay? So let's get started. Okay, let's talk about the criteria for left ventricular hypertrophy. So the first criteria I want to teach you is the Sokolow-Lyon criteria. And for the Sokolow-Lyon criteria, you're gonna look at the S wave in V1, and you're gonna look at the R wave in V5 and V6. You're gonna add the S wave in V1 to the largest R wave, either in V5 or V6. If it measures more than 35 millimeters, then that's positive for left ventricular hypertrophy. In addition, you could also look at AVL. And in AVL, if the R wave is taller than 11 millimeters, that's also positive for left ventricular hypertrophy, okay? Another criteria that you should learn is the Cornell criteria. And for the Cornell criteria, you're gonna look at the R wave in AVL again, but this time you're gonna add it to the S wave in V3, okay? If it is a male, it should measure more than 28 millimeters. If it is a female, then 20 millimeters is enough to meet the criteria, all right? Very good. Now, in the other hand, right ventricular hypertrophy, in this case, if you have right axis deviation, then you're actually meeting criteria for right ventricular hypertrophy. Now, an important detail is that most cardiologists feel that for you to be able to call it a right ventricular hypertrophy, the right axis deviation must lie beyond 100 degrees, okay? So for us to make sure that's happening is that we need to make sure that the S wave is bigger than the R wave in lead 1, okay? So if you have biphasic waves, then you can really be sure. But if that S wave is larger than the R wave, then yes, you're meeting criteria for right ventricular hypertrophy. Very good. Another important thing to know about the right ventricular hypertrophy is that you can also see changes in the R wave progression in the precordial leads, okay? So normally in the precordial leads, you're gonna start very negative with S waves, and as the wave of depolarization progresses from the right side of the heart to the left side of the heart, you're gonna start seeing that R wave grow from negative deflection S waves to R waves in V5 and V6. So in right ventricular hypertrophy, it might be the other way around. You might have tall R waves in V1 and V2 because V1 and V2 actually lie on the right side of the heart, where the stronger depolarizations are. So you're gonna see tall R waves in V1 and V2, and as it progresses from V1 to V6, they're gonna become shorter until you have dominant S waves in V5 and V6, okay? Let's see an example of that. So normally, it should look like the example on the left. Normally, you should have tiny R wave in lead 1 and a large S wave, and as it progresses from V1 to V2, it becomes taller, then to V3 and V4 taller, until the R waves are the tallest on V5 and V6, okay? In right ventricular hypertrophy, we don't see that. In fact, we're gonna see a positive deflection in V1. It's gonna be an R wave. If you can compare that to the normal side here, you see here we have a dominant S wave, that's normal, but in right ventricular hypertrophy, we have a dominant R wave, that's abnormal, okay? And as you can see, when it progresses through V1 to V2 and V3, you start seeing that that S wave starts getting bigger. So it's the other way around as it should be. And a quick shortcut that you can use is that if you see a tall R wave in V1 and a large S wave in V6, that's abnormal. That's right ventricular hypertrophy. Compare that to the other side. You see a small R wave and a large in V1 and a large R wave in V6. That's normal, okay? All right. Okay, let's do a clinical case together. So a 78-year-old man comes to see you during your outpatient cardiology rotation. He complains of lightheadedness when standing up and near syncope. During physical exam, you notice a systolic ejection murmur best heard at the right parasternal border. You decide to perform an EKG. What does the EKG show? All right. So, as always, let's be systematic. Let's follow our mnemonic. Our mnemonic is erratic, okay? So let's write that down. All right. So remember, E is for EKG, then R is for rate. So let's check rate. So here we don't have a rhythm strip. We can still use the first method that we taught on our first video on heart rate, okay? So we can see here, we can say 300, 150, 100. So it's around 100 beats per minute. Then the next R is for rhythm. And for rhythm, we have the 5 questions. First, are there any P waves? And we look, and yes, we see P waves. Is there a P wave for every QRS? And we look, and yes, there's a P wave for every QRS. Is the QRS narrow or wide? It's a narrow QRS. Is the rhythm regular or irregular? It's a regular rhythm. And then is the PR segment prolonged, more than 200 milliseconds? And it's not, it's normal. So we can say it's normal sinus rhythm. Then we look for axis. So we just learned that how do we assess for axis? We look at V1 and we look at AVF, and we see a positive deflection on AVF, so it's looking towards it, and a negative deflection on AVF. So that means that there might be a possible left axis deviation. So we look at lead 2, right? So in lead 2 is still positive, so we know that is still normal axis, okay? So there's no left axis deviation, it's still a normal axis, okay? So normal. It does not lie beyond minus 30 degrees. Then T is for QT interval, and we look for T waves here. There's a T wave here. And we need to make sure it's not more than 50% in between QRS and KRS, and it's not. It's normal. So it's normal QTC. So no prolongation, normal. Then I is for ischemic changes, and we'll look at that following anatomic regions, right? So first we look at lead 1, and we look for T wave inversions, Q wave, ST depressions, and we see a little bit of an ST depression here. Then we look at AVL, and we see some T wave inversions here. and then we look at V5 and V6, and those are normal, okay? Now, let's look at the inferior portion of the heart. Lead 2 looks normal. Lead 3, this actually looks like a Q wave, right? Because there's no positive deflection. So that might be an old infarct. And then we look at AVF, and again, there might be a tiny deflection there, but it could also be taken as a Q wave. So there might be an old inferior wall infarct, okay? And then we look at the precordial leads, and looking at V1 looks normal, V2 and V3, V4 and V5 and V6, they all look normal. So no ischemic changes there. So we do have some abnormalities, and we'll talk about it. So we have a possible old inferior infarction. And now let's look at chambers. And for chambers, we're gonna look for the Sokolow-Lyon criteria for left ventricular hypertrophy, and for right axis deviation, which there is none. It's normal. There's a normal axis, so there's no right ventricular hypertrophy. But let's check for left ventricular hypertrophy. So thinking about the Sokolow-Lyon criteria, the first thing we could do is check AVL. If it measures more than 11 millimeters, then that's positive. And looking here, we can see yes, it measures more than 11 millimeters, okay? So now it's meeting criteria. But we can also check for the other aspect of the criteria. So we look at V1, and we add up to V5 and V6. It has to be more than 35 millimeters. So let me count. Yeah, it's measuring more than 35 millimeters. So it's meeting criteria for the Sokolow-Lyon criteria with both aspects. The AVL is measuring more than 11 millimeters, and the S wave in V1 and R wave in V5 and V6 are measuring more than 35 millimeters. We can also use the Cornell criteria, and for that we said that we measure AVL, and we add that one, the R wave in AVL, to the S wave in V3, and for males you have to measure more than 28. So in this case, let me count again. It's actually almost there. So regardless, if you have Lyon-Sokolow criteria is positive, then you already have left ventricular hypertrophy. You don't have to meet both of them, okay? So we have left ventricular hypertrophy. So let's talk about these findings, these ST depressions, and these T-wave inversions. So when you have left ventricular hypertrophy, you can also see secondary repolarization abnormalities because of this hypertrophy, okay? And we'll see that in a minute. So let's talk about repolarization abnormalities, okay? So when you have left ventricular hypertrophy, you're gonna see that an abnormal depolarization is going to give you an abnormal repolarization. And that T-wave inversion is going to have a specific morphology. So as you can see here, this T-wave inversion has more of a downward slope, and then the upward part of the T-wave, the second part of the T-wave, is actually more abrupt. So it's kind of downwards and abrupt. In the case of ischemia, you're gonna see that it's more of a symmetrical T-wave inversion, just like this. So mirror image, symmetrical, that's more ischemia. Now when you have this downsloping and then that abrupt upwards second part of the T-wave, you can see it's not a mirror image. This is most likely a secondary repolarization abnormalities. You can see these both on left ventricular hypertrophy and right ventricular hypertrophy, although it's more common in left ventricular hypertrophy. So in the case of right ventricular hypertrophy, V1 and V2 lie right on top of the right ventricle, so they're gonna have the tallest depolarization. In this case, is gonna be a very tall R wave because of the R wave progression gets disrupted in the precordial leads, right? versus in left ventricular hypertrophy, the tallest wave are gonna be seen on the left portion of the heart. So lead 1, AVL, V5, and V6. That's where most commonly we're gonna see these T-wave inversions. And if we go back, we can see that AVL is on the left portion of the heart. We can see that T-wave inversion with that abnormal downsloping and then abrupt upward stroke, okay? All right, my friends, that's it. I really hope you found this video helpful. If you did, please consider subscribing, sharing, and liking this video. It really does help build this channel. And as always, I'll see you next at the Cardiac Academy.